Okay, so thank you everyone for joining today's Q&A session on the kidney. And I'll be reviewing in simple terms what the kidney does to try to keep you healthy and how you can keep your kidney function from getting worse, and also how you can assess your kidney function easily when you go to the doctor's office.
Mario?
And I'll also be discussing some common diseases that affect the kidney.
Mario?
Maria, yes.
Okay, can everybody hear?
What?
Great.
Yes.
Okay, so just to start off, the kidneys are located in the back, in your back, more towards the back than the front. And each kidney weighs about 1/3 of a pound. These are the kidneys right here. And they're sitting in the back of your abdomen. It's hard to tell from this picture. Now, this is a rather interesting slide. Over here, you can think of this as the function of the kidney, with 100% being normal. And then on this axis shows a number of numbers that represent age, going from 50 years old to 90 years old. There's two curves. One is blue, one is red. The blue curve represents men and the red curve women. And there's actually three different lines here. The lines in the middle is the average, or the average for men and women. And the lines on top and bottom are the range that you can see, because not everybody's the same. So what does this slide show? What you see here, starting at around 100 for both men and women, is that as you get older, your kidney function actually declines. Women a little more than men in this particular analysis. And so by the age of 90, let's say, your kidney function has gone from about 100 down to almost 60%. You've lost 35 to 40% of your normal kidney function. Now, this is not a disease. This is what occurs to all humans as they age normally. And this is important because most doctors don't realize this. So if you get your kidney function assessed when you're in your 80s or 90s, I see there's a mistake here. That should obviously be 85. But if you get your kidney function assessed when you're older, the doctor often thinks you have some sort of kidney disease. They don't realize that it could have fallen just from normal aging. If they are aware of it, then they need to compare your kidney function to this new lower level, so that if your kidney function, let's say, when you're in this age group is, let's say, 40% or 25%, that would definitely be below normal. But if the result comes back at 60% or 65%, even though when you're 50, that would represent some sort of illness, at this age group, it just represents normality. So just remember that if you have a grandparent, or if you're in that age group now, that your kidney function needs to be, is relative to what the normal decline in kidney function is. Now, you might ask yourself, why is there a decline in kidney function? Why don't our kidneys just stay the same? And that is something that's actively being researched. What we do see is that the kidney tissue changes as you age, and there's loss of function in kidney tissue. And that explains it sort of on a global general level, but why the tissue changes and what is exactly going on at a more subtle level is not well understood currently. Now, what this picture depicts is that we break down the different ranges of kidney function into groups. And we actually call these different stages of what we call CKD stages. CKD, not shown on this slide, but the letters CKD stand for chronic kidney disease. And we have different so-called CKD stages. So if your kidney function is over 90, if it's 100% of normal, you don't have any CKD stage. But if it's, let's say, between 90 and 100, that's called CKD1, a very minimal, mild or slight decrease in kidney function. if you belong to this stage, CKD5, you have less than 15% or so of your kidney function. That's quite severe. And it turns out that there's a big leeway as far as how much kidney function you have to have left before you need what we call renal replacement therapy. And another word of saying that is that you have to go on dialysis, either hemodialysis or peritoneal dialysis, or get a kidney. That usually doesn't occur till your kidney function is this impaired, till you reach CKD5. If you have CKD4 or CKD3, even though your kidney function may be 30% of normal or 20% of normal, you still have enough kidney function not to need dialysis or a transplant. It's only when you have very, very severe loss of function, and we're referring to both kidneys now, it's not just one side, both kidneys, when you get down to about 15% of normal, that's when you need so-called kidney replacement therapy. Now, what is the kidney made up of? It's made up of these little units that we call nephrons, and there's about 1 million nephrons in each kidney. Now, you can't see these with your eye. You have to look under a powerful microscope. What do these nephrons do? They have two components. The first component is what you would think of as a filter, like the filter in your bathtub, or a filter, the Brita filter in how you purify water, or any filter. The kidneys have the first part of the nephron acting as a filter. And what are we filtering? We're filtering out the cells in blood. So the cells in blood cannot get through the filter, the red cells, white cells, and platelets. The rest of the fluid gets right through, and it gets through into the rest of the nephron. Now, the rest of the nephron is not a filter. The rest of the nephron actually has the capability of taking substances from your blood and putting them into the inside, or taking substances that got through the filter and passing them back to the blood. So things can go in both directions. And what you have at the end of all this complicated structure, and again, there's 1 million of these in each kidney, at the end you have the final urine. So urine, it turns out, is a very complicated solution. It's not just water with a yellow color to it. It has a lot of different, what we call electrolytes and chemicals, such that the final chemistry of the urine is such that it allows you to stay alive from day to day. What the kidney is actually doing, if someone asks you, what does the kidney do? Some people would say simplistically, it removes poisons from our blood, and that's true. But what the kidney does more subtly is it actually keeps the chemistry of our blood constant. The chemistry of our blood has to stay constant, and actually all the cells of our body, the chemistry has to stay constant. Otherwise, they won't function normally. Now, why would the chemistry change? Well, the chemistry changes because we eat. We eat 3 meals a day, and we're throwing all sorts of substances, electrolytes, water, different chemicals, different organic substances into our bloodstream, and that can't be allowed to occur on a daily basis, or else the blood chemistry would change so much we wouldn't be able to survive. The kidney recognizes all the changes in the chemistry and makes sure that because of what it gets rid of, the chemistry returns to normal. And it's the abnormal chemistry in our blood that occurs when the kidney function gets down to about 15%. Now, there's many functions that the kidney has that I'll talk about in a minute. So when we're talking about the CKD stages, or the word function of the kidney, we're only referring really to one of the functions, and that's the filtering function. When the filtering function of the kidney gets down to 15% of normal, that's when you need renal replacement therapy. In fact, people who have abnormalities with the filter may have totally normal function of the rest of the nephron. Or there's people that have abnormal functioning of the nephron and the filter is normal. Those people don't need dialysis, even though there's disease affecting the rest of the nephron. So when we refer to kidney function, we're isolating only one component of what the kidney does, and we're specifically referring to how much is being filtered here. And we'll talk about more of that shortly. So the kidneys have multiple functions, as I mentioned. What are some of these functions? Well, one of the functions is to get rid of an electrolyte that's called potassium. Potassium is in many of the foods we eat. It's in bananas, it's in fish, it's in the proteins we eat, in fruits, but watermelon, oranges. And it's essential that our blood potassium stays within a fixed range, because if the potassium goes too high or too low, we get abnormalities in the electricity in our heart. So our heart has a pacemaker in it that you can think of as electricity that fires off and it makes the heart contract, and that's happening about once a second. But potassium can affect that transmission of electricity. And in fact, if you give someone too much potassium, the electricity in the heart stops and you can stop the heart. So it's very important that the potassium is kept within a very narrow range, and it's the function of the kidney to recognize the changes in the chemistry of your blood that occur when you eat bananas tonight and get rid of the exact amount of potassium that was in the bananas in your final urine, and that keeps the blood potassium what it should be. The kidney also gets rid of what's called nitrogen. Nitrogen is in all the amino acids and protein that we eat. So when you eat hot dogs or steak or hamburger or fish, there's a lot of nitrogen in the protein that is in those, or yogurt or cheese or milk. And the kidney has to get rid of that nitrogen. It gets rid of the nitrogen not as free nitrogen, but in the form of a chemical called urea, U-R-E-A. And the liver actually takes the nitrogen that we eat and turns it into urea and then puts it into the blood, and the kidney gets rid of that urea. So the nitrogen in urea is how we get rid of the nitrogen from the protein that we eat every day. The kidney also controls your blood pressure. Now, it turns out that about 45% of Americans 18 and older have high blood pressure, and the blood pressure is defined as 130/80. It used to be higher, but in the last 4 or 5 years, the American Heart Association has decreased that number. And it's amazing how many people have a high pressure. The problem with high blood pressure is most people ignore it. You don't feel anything when you have high blood pressure. So you don't care about taking your pressure. And also that's another reason people don't take their pills. Now, what happens if you have high blood pressure that's untreated? Well, it increases your chance of getting a stroke. It affects how the heart responds, because the heart actually gets thicker. The muscle gets thicker as the blood pressure goes up, and a thick muscle in the heart is not good for the heart function. You don't want to have that. High blood pressure also appears to affect kidney function per se. Even though the kidney affects the pressure, it's a vicious loop. When pressure goes up, that can potentially affect the kidney function. And so it's very important, because of these vital organs, to keep your blood pressure within a normal range. Now, it's more complex than that, because the blood pressure isn't one number. First of all, it varies throughout the day and the night in a normal person. And if you measure someone's pressure around the clock, you get a whole pattern of low, then going high, then coming down again. And so there's what's called a diurnal variation of blood pressure. So that's important, because some people may have high blood pressure in the morning and not the rest of the day. Others may have it at 7 in the evening and not the rest of the day. So it's very important when you measure your pressure to first measure it at least 3 times a day to get the pattern of where the abnormality is. And I'll talk about why that's important to know in a minute. The other point is that the blood pressure is different when you're lying, sitting, or standing. So if you are interested, or there's some issue with your blood pressure, the first point is that we don't care as much about the blood pressure in the office, because there's something called white coat syndrome, where your blood pressure is always higher when you see the doctor because you're nervous. So we care about, more importantly, what your blood pressure is when you're home. If you're measuring at home, again, make sure to measure it 3 times a day initially if there's some issue with your blood pressure, and get readings over weeks so that the doctor can get the pattern. Record the numbers either in a notebook or an Excel sheet, however you like. And then when you see the doctor, you bring in all the numbers, and they can start getting familiar with what your particular pattern is. Also, you should measure the pressure the same way. Don't do it one time standing and the one time lying down, because just at the same second, if you go lying, standing, or sitting, you're going to get 3 different numbers. So always measure it the same way, whatever you're happy with. People tend to do it lying. Some people do it sitting. Now, there are instances where we want you to get the pressure sitting and then standing, because some elderly people have a much greater drop in their pressure when they first stand up, especially those on blood pressure pills. And that's why an older person on blood pressure pills has to get up very slowly, because they can get lightheaded. And the reason they're feeling lightheaded is their pressure's dropping, and then they can actually fall to the floor. So it's a possible reason why an elderly person can break a hip. So you have to be very careful in an older person when you tell them to stand up suddenly. But there are people who we want to see what the magnitude of the drop is in pressure when they first stand up. There's a normal drop, but some people have an excessive drop, especially the older folks. So it's important to know also when your blood pressure is going up, because that will determine in part when the doctor will tell you to take the blood pressure pill. So there's a delay in when the pill starts working. So when you take it, it doesn't work right away. So let's say your pressure's high around noontime every day, or in general. The doctor will tell you to take that pill in the morning when you have your breakfast. There's a delay of onset, but by the time noontime comes around, it'll start to work. It wouldn't make sense to tell you to take the pill in the evening, because it's going to be working all night when you don't have a problem with your pressure. And by the time the next day comes at noontime, the pill's already not working anymore. On the other hand, if you have high blood pressure in the morning, the doctor's going to tell you to take the pill at night. Usually we don't tell people to wake up in the middle of the night to take the pill. So there is some delay there. It'll start working around 3 or 4 in the morning, or maybe a bit earlier, but it'll still be working in the morning enough to take care of that high pressure. If you have pressure that's high in the morning and pressure high at night, the doctor may prescribe a long-acting pill that works 24 hours, or may give you one in the morning and at night to cover the entire day. Unfortunately, a lot of doctors don't go to this length of thinking, and you have to be aware of it so that you get the best care if you have high blood pressure. The kidney also is important for preventing anemia. The kidney makes a hormone called erythropoietin. This has nothing to do with its filtering or electrolyte transporting function. It actually is a hormone creating organ, like your thyroid gland makes thyroid hormone, like your pancreas makes insulin. The kidney makes erythropoietin, and this chemical goes into the blood, and it goes to the bones, particularly the bone marrow, and tells the bone marrow to make red blood cells. That's where your red blood cells are made. And the more erythropoietin the bone sees, the more red blood cells the bone makes. And here's the red blood cells in this cartoon coming out. But if you don't have enough erythropoietin, your bone marrow is not going to make enough red blood cells, and you'll become anemic. That's what anemia is. It means there's not enough red blood cells. So people who have kidneys that are very diseased don't have enough erythropoietin, and the doctor has to prescribe it. It's typically given under the skin. It's called a sub-Q injection, a tiny little needle you put under your skin and inject it. Lasts a week or 2. There's no pills for this yet. There's newer drugs coming out, though, that aren't erythropoietin, but they can correct the anemia in kidney patients, and they are pills. They just haven't been approved in the United States yet. The kidney is also important for keeping your skeleton healthy, keeping your bones healthy, in particular the calcium and phosphorus in your bones, because the kidneys make the active form of vitamin D. It's called 125 vitamin D. Now, when you go to the pharmacy and buy vitamin D, you're buying 25 vitamin D, but that's not the form that works on calcium and your bones. The kidney takes that compound and turns it into something called 125 vitamin D, and it's the 125 vitamin D that's the active form. So people, again, with poorly functioning kidneys or kidney disease don't make enough of this hormone, and the doctors have to sometimes give this. And we'll give a lot more 25 vitamin D also. A typical person might take 1,000 to 2,000 units a day. Our kidney patients are getting 50,000 units once a month. Huge amount would be a typical dose. And some of them are getting the 125 vitamin D in addition. So when you have diseases of the kidney, you can almost predict what's going to happen. Because the kidney can't get rid of salt and water, you're going to get fluid overload and swelling of your feet and maybe high blood pressure. Something that's not as predicted is when your kidneys reach CKD stage 5 or they fail altogether, you lose your appetite and you feel nauseous. And also the food doesn't taste normal. You get abnormal taste. Your pressure goes up, as I mentioned, because you're retaining water and salt. And you get other blood chemistry abnormalities. These are the symbols, the chemical symbols. Na is sodium, K is potassium, Ca is calcium, Mg is magnesium, P is phosphorus, HCO3 is bicarbonate. All these electrolytes can become abnormal in your blood because the kidney is not regulating them properly. You get anemic, as I mentioned, because you don't make erythropoietin. A number of patients with kidney disease either are depressed or they have symptoms that appear like depression. And the doctor has to distinguish, is the patient truly depressed or do they just have symptoms that resemble depression, like not being able to sleep or sleep-night reversal, where you sleep during the day and not at night, or you lose your appetite, or you don't want to get out and be seen by other people. It can resemble depression, but it may not be true depression. And the doctors have ways of distinguishing the two. The sleep disturbance I mentioned, some kidney patients just can't sleep at night and they sleep either intermittently throughout the day or they have frank reversal of sleep patterns. And the abnormal taste I mentioned, there's a new intravenous injection that just came out that can help with that, but it's still in research phases. Now, people are not quite sure why this occurs. There's some theories, but it's still a major problem. And what we tell patients to do is to just put a ton of spices or flavor on the food to try to make it a little more appealing. But in many patients, that still doesn't work. There's something here that's not shown also, is itching, which you can get when you have severe kidney disease. And why that occurs, again, is not well understood, but there are some new drugs for that that are coming out that will at least help with the patients who are on hemodialysis. So how do we test for kidney disease? We have a simple blood test called creatinine. Creatinine is a chemical that's filtered by the kidney. So when the filter is not working well, the creatinine goes up in the blood. And it's in proportion to how much decrease in filtration ability there is. So when the creatinine is 1, that's 100% normal filtering and function, or what we call function of the kidney. But again, when we say function, we're referring to the filtration. We're not talking about erythropoietin production or vitamin D production. We're not talking about potassium excretion or salt excretion or water excretion. We're just talking about the filtration. That's what the creatinine assesses. But that's what we care about the most, because this is what determines whether you need to go on dialysis or not. So when the creatinine's 1, your kidney functions about 100. When the creatinine's 2, you have half your kidney function. When your creatinine's 4, you have a quarter of your kidney function. So it's a very nice, simple test, and people get it measured all the time. They just don't realize it. The doctor will then take this and convert it to something called eGFR. And that is just an assessment of what the filtration rate is, how much fluid is coming through all these filters. It's an estimate. It's not a true measurement. It's based on a mathematical equation, based on your age and height, sex, this kind of thing. So it's an estimate. But so you'll see both numbers. You'll see creatinine and eGFR in your medical record. But they basically are saying the same thing. The other test we do for kidney disease is we measure something called the amount of protein in the urine. Normally, the amount of protein in the urine is very low. We can grossly tell if there's protein sometimes because when there's a lot of protein in the urine, there's a ton of bubbles. Most of the time, bubbles are from air, so you shouldn't get worried. But sometimes if you see a lot of bubbles and it's not due to air, it's potentially due to protein. We can also assess whether there's protein in the urine with this stick up here that we call a dipstick. We stick it in the urine and the colors will vary depending on how much protein there is in the urine. And the doctor looks up the color on the bottle and can tell roughly how much protein there is. If we want to know exactly how much protein there is, we send off a sample of the urine to the lab, and the lab comes back with a number. This is more a general assessment to get an idea, but it doesn't tell us exactly how much protein there is in the urine. The reason it's important to know that is when the filter becomes abnormal. When this filter becomes abnormal, not only does it filter less water, which we call the kidney function, it also allows protein from the blood to leak into the urine. Normally, this filter prevents protein from coming into the rest of the tube here. So when you have a disease of this, not only does it filter less water, it allows protein to leak, and that's what comes out in the final urine, and that's what you're seeing here. Now, the other thing the filter prevents is it doesn't let red blood cells that are made in the bone marrow. You remember the story with anemia? Normally, those red cells don't get into the urine. They stay in the blood. But if the filter is not working normally, it will allow red blood cells to come through into the rest of the tube, and that will get into the urine. Now, there's different quantities of blood in the urine. You could have obvious blood, this tube here, or it could be less. This one could also have blood, but you can't see it with your eye. We always look under the microscope to see if we see red blood cells under the microscope. We call this microscopic hematuria because it's only seen under the microscope. We call this macroscopic hematuria because it can be seen with the human eye. Now, a common complaint we'll get is, doctor, I have blood in my urine, and the first question you should always ask is, did you eat beets last night? Because beets are a very common cause for having red urine. And so the difference is that it'll go away as the time increases after having eaten the beets, whereas this will continually be there. Another entity that can occur is a bacterial infection. It tends to occur in sexually active women in their 20s or younger, but can occur at all age groups. Another big peak is in elderly patients, usually women in their 70s, 80s, and 90s. And in an elderly person, in a younger person, it presents with burning urine and going a lot, going frequently and burning. In an elderly person, there may be no symptoms other than they're acting weird. They're more confused, they're sleeping more, their behavior changes. And you always have to suspect in someone in a nursing home or an elderly parent or grandparent, when they start acting strange, the first thing you have to think of is, do they have an infection? Most often it's a urinary tract infection. It can be any infection though. You just have to always be suspicious of altered behavior in an elderly person. You have to connect that with urinary tract infection, the most common cause being a urinary tract infection. And many elderly people, we have to put them on an antibiotic, a small dose, and they just stay on it, and it prevents future urinary tract infections. We don't want to give them too much antibiotic because then they can develop a bacteria that's resistant to the antibiotic, and that leads to other issues. So we give them a lower dose, and it just sort of holds things without allowing the bacteria to become resistant. But if we feel there might be a urinary tract infection, we look on the urine under the microscope. These are bacteria, all these little black dots you should not be seeing. We also take the urine and put it on this, what's called an agar plate. And the agar has, it's like a solid gel, so you can drop the urine on top, but it also has food in it that the bacteria love. So if there's any bacteria at all, you'll get the bacteria dividing and dividing and dividing, and this one little bacteria here will turn into a whole colony of thousands of bacteria. Each of these is a colony of bacteria. And what also will be done in the lab is to put a little piece of paper, you can think of it, a paper disc impregnated with different antibiotics. So you can have an antibiotic here, another one here. If the bacteria that's in the urine is sensitive to the antibiotic, you'll end up with a little rim around the paper of killed bacteria. And that's how the doctor can tell what's called the sensitivities of the infection, what antibiotics the bacteria will be sensitive to are figured out on a plate like this. Now, at first, you don't have this. This takes about 48 to 72 hours or more till you get the information, because it takes time for these bacteria to grow. So the doctor will just take a guess and initially just give you an antibiotic and modify that guess 48 to 72 hours later as needed. Now, what are some of the diseases that can affect the kidney? We talked about if the kidney is diseased, how it manifests clinically. Now we're just going to talk about the diseases that can impair the kidney. They all lead to the same things. They all lead to swelling of the legs, nausea, loss of appetite, anemia, bone problem, all the things we talked about. But the initiating event that harms the kidney differs. The most common cause of why the kidneys get diseased is diabetes. 50% of the kidney disease in the United States and in the world is caused by diabetes. Now, the public tends to think of diabetes as a sugar problem, and that is true. But what's not recognized is it's also a blood vessel problem. And when you have diabetes for a long time, in many patients, their blood vessels, this is a nice normal one, get diseased. And what happens is you get fatty deposits on the inside that narrow the so-called lumen of the blood vessel. You can get blood clots. If this is very severe, the artery can actually not function. And if this happens in the coronary arteries in your heart, you're going to get a heart attack. If this happens in the arteries in your brain, you're going to get a stroke. So that's number one. It affects the arteries throughout the body, including the kidney. So this can be a cause for decreasing function of the filter because there's just not enough blood getting to those filters. But the other point with diabetes is the filter itself. This is actually a cut of one of the filters. So you can think of it in, normally it's a three-dimensional sphere. This is just a cut right through it. This is what it looks like. This is a normal one. This is a diabetic filter in the kidney. Remember, we have 1 million of these. But you can see here the filter's filling up with all this purple junk. And if this continues to go on, this filter is not going to be functioning very well. So in the kidney, there's sort of two reasons that you get abnormal kidney function. One, the blood flow to the kidneys is not normal because the blood vessels get diseased. And two, the filters per se get diseased. And so if you go to any dialysis unit or any kidney transplant program, half the patients there are going to be diabetic. Remember, there's two types of diabetes. There's type 1 and type 2. Type 1 is where the pancreas stops making insulin. That's type 1. Type 2 diabetes is where your pancreas is fine, your insulin secretion is actually better than normal, but the insulin doesn't work at the tissues. That we find in people who are overweight or obese. When you get to become severely overweight or obese, insulin doesn't work as well. And that's how you get diabetes. Now, why, when insulin doesn't work as well with type 2, or you don't have enough insulin with type 1, you end up with blood vessel problems and kidney filter problems, is a very complex story that is really a separate talk. Another disease of the kidney is called IgA nephropathy. It's very common in Southeast Asia. These patients present with, perhaps they'll say, you know, on Saturday I developed a fever, I thought I had a cold, and then Sunday I started to pee and it was bright red blood. That's a common story. Or they might just say I started to pee and there was bright red blood and it continued. This is a disease of the filter. This is another picture of the filter of one of these patients. You can see a lot of purple things here. These are actually cells, and there's too many of the cells here. This is a severely inflamed filter, and you can see it's getting all blocked off. Not like the diabetic filter where there's this purple substance coming into the filter. Here there's too many cells, and the filter is not filtering well. And there's another compound, it's actually what we call an antibody called IgA, that's shown in green here, that is actually attaching to this filter. And normally you never see this. So it's called IgA nephropathy. And it could lead not only to blood, too much blood, and also protein, as I mentioned, not shown here, but it can also decrease the filter where you go from CKD stage 1 all the way to 5, and you may need to go on dialysis or get a kidney transplant. Another disease of the kidney is not a disease of the filter, not a disease of the tubes that I showed, but you can get kidney stones. The kidney stones are not in the tissue of the kidney where the filters are, but outside here in what we call the kidney pelvis, or the collecting system, where all the urine starts to collect from all the millions of nephrons that are here. This is where all the urine finally gathers together and comes out. You can get a stone anywhere. Some people have stones within the tissue of the kidney. We call that nephrocalcinosis, but we're talking now about stones in the collecting system that's either here up high or can be down here in what we call the ureter. The ureter is the tube coming out of the kidney that takes the urine to the bladder. Now, millions of Americans have this. There are many different types of stones based on their chemistry. There can be calcium oxalate stones, calcium phosphate stones, uric acid stones, cysteine stone, xanthine. There's many different types of stones. They have different properties and characteristics, but one thing they have in common is if the stone won't come out and gets blocked here, the pain can be worse than pregnancy. It's the worst pain, some people say, that a human being could feel, and it's pulsating, and it goes from the back, the upper part of your back where the kidney is, around the front all the way into your groin. It's extremely painful. If the stone can be passed, the pain is less. What we typically do if we suspect a stone in the emergency room is we give the patient morphine just to stop the severe pain. They're usually nauseous, they're throwing up, and they're crying. It's very severe. And then we'll work out afterwards what to do. There are many ways of getting rid of the stones, which again is a separate talk, but some of the ways are to put an ultrasound wave into the kidney, and that's done through the outside. You're standing in water, or you're standing in a device, and the device shoots ultrasound waves through your body, targets it right to the stone. You don't feel anything, and pulverizes it. Another way is the doctor, usually a urologist, not a nephrologist, will have to go in with a device that pulverizes the stone. And they use different devices. Now they're using lasers actually to blow these stones apart. And the idea is to make small enough pieces where the pieces will all come out, because you have a finite diameter here, and anything over 2-3 millimeters cannot get through. This is another disease of the kidney. We call this polycystic kidney disease. You may have heard of this. And this is a genetic disease where the kidney over time, in many patients who have the gene mutation, not all, but many of them develop these big grape-like blebs coming out of the kidney. So instead of having a nice smooth surface and contour, you get these big blebs. And coupled to that is the kidney tissue starts getting destroyed, and you get abnormal kidney function. And some of these patients have to go on dialysis. Now, it doesn't occur in all patients, and it doesn't necessarily start at birth, even though you're born with the mutation. Some people have completely normal function and appearance of the kidneys until you get into your 40s or 50s. You can even have two people in the same family, a brother and a sister, with the same mutation, and one of them develops the abnormality, the other doesn't. So there are other genes in our DNA that affect the severity and the time course of the disorder, even if you have the exact same mutation. It's passed down in an autosomal dominant fashion, which means you only need one of your parents to have the abnormality. And in many patients, we can't get a good family history. People will say, well, I know my father died in his 70s. They said he had some kidney problem. And I know my grandmother, his mother died of some kidney problem, but I don't really know what it is. That's sort of the typical story we get. This is another disease called lupus. It tends to occur in young women. And basically, in this disease, the body starts attacking itself by becoming inflamed for no apparent reason. And the kidneys are one of the organs, but all organs can be affected. It can occur in your brain. We call that cerebritis. It can occur in the heart. We call that myocarditis. It can occur everywhere, including the kidney, and it affects the kidney filter again. What you see here is this young girl has red cheeks. We call this a butterfly rash. It's not really a rash. It's just that the blood vessels under the skin here are dilated from the inflammation, and there's more blood flowing here, so it looks red. Other manifestations are loss of hair, which we call alopecia. They have sensitivity to the sun, so they have to be careful. They have what's called photosensitivity. But the kidney filter here, here's a normal one below. This filter is filled with inflammatory cells, and it's not going to function normally. So these patients can have different types of inflammation. So it's complex disease in the sense that the inflammation doesn't look the same in all patients. And we've now got a subcategorization of what the kidney pathology looks like. And the treatments differ. Some patients will stay at CKD2 their whole life. Some will actually get better, go to CKD1 depending on the treatment. Others may go all the way to 5 and then end up on dialysis. Another rare disease is kidney cancer. Here's a CAT scan of the abdomen. This is your spine here, this bone. This is what a normal kidney looks like, this horseshoe shape. And this is the back, this is the front. So the kidneys are in the back, as you can see. And this kidney here has cancer in it. You can see it just looks very weird compared to the normal kidney. And this is a cartoon. We have different ways of treating this now too. The goal always is to spare the normal kidney tissue rather than take the whole kidney out. Even though you have one kidney left, still the doctor tries to preserve as much of the normal kidney on the side that has cancer as possible. And sometimes they'll do a partial nephrectomy where they take out part of the kidney, or they might try to destroy the tumor with different methodologies. Radio waves is one example. But the goal is to try to keep as much kidney function as possible. Because if you take out the whole kidney, there's one kidney left. What if that other kidney gets diabetes or another disease, and the patient's going to end up on dialysis? Now, every year, there's about 100,000 new people needing renal replacement therapy. And in the United States now, it varies. There's about 650,000 or so people on dialysis. And every year, about 100,000 people who were on dialysis pass away. Now, in part, this is because it tends to be a disease now of older people. The average age of people on dialysis now is going up and up and up all the time because we're more successful at preventing people from going on to dialysis. We're more successful at keeping people CKD2, 3, 4, rather than rapidly over the years going from CKD2 all the way to 5 and then having only 15% of their kidney function left. There's newer drugs coming out all the time to slow down the progression of the loss of filtration. And that is one reason why this is not going up at the rate people used to think it was going to go up. People predicted it would be a lot more than 100,000 people a year going on to dialysis. And that's because of the success of our treatments. Because the number of people going on is roughly equal to the number of people dying each year, this number stays pretty constant. There are also 100,000 people roughly in the United States waiting for a kidney transplant. So what are some of the forms of renal replacement therapy? Well, hemodialysis has been around since the 1940s. It was actually invented in 1942 in Nazi-occupied Holland by a doctor who worked out the methodology. And it improved over time, but basically we're doing the same type of thing. We have a machine which looks complicated, but all basically it is, when you strip it down, is something with a pump in it and sensors. There's pumps and sensors to measure the pressures and everything. But basically what's done is blood comes out of the patient. There's a pump that pumps it, and it goes into this thing here. This is the guts of the device. Oops, sorry. This is the guts of the device. It's called a dialyzer. And the blood comes in here, and then it's broken up into tiny little, you can think of them like straws, but there's thousands of them in here. The blood goes into the center of each of them, and then they all collect at the top, and the blood goes back to the patient. Now, obviously that wouldn't do anything. We would just be taking blood out of the patient and putting blood back into the patient. But there's another solution that flows into here, and that comes in here and goes out here. So outside these thousands of straws, there's room for another solution, and that's what we call the dialysate. And that's a solution that the doctor prescribes. And so inside the center of these tubes is the blood, but outside is the dialysate. And because the chemistry of the dialysate is different from the blood, electrolytes and poisons can actually leave these tubes. You can't see any of these tubes here, they're too small, but it leaves the tubes and goes into this outside solution that's bathing all the tubes. And that solution now that carries the poisons and the extra electrolytes that we don't need then goes down here into the drain and the floor. So we have this solution constantly going through and coming out. We have blood constantly going into this thing and coming out. And that's how we're able to change the chemistry of the blood shown here that's returning to the patient. And we do this for about 3.5 hours, 3 times a week. Patients are either done Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And this does not by any means replace the normal function of the kidneys, which are functioning, 24/7. This is the minimum amount of treatment you need to keep someone alive. Obviously, ideally, we would be doing this around the clock, 7 days a week, but that, from a practical and financial reason, obviously can't be done. So this is sort of the minimum regimen that's been worked out over the years that keeps people's blood chemistry relatively constant and allows them to survive. Now, obviously, when we're not doing it, when we stop the treatment after 3.5 hours, until the next 2 days later, their blood chemistry is becoming abnormal again. So we're constantly correcting it, but we're doing it very rapidly and only 3 times a week. In between, the blood chemistry changes. For instance, these people, most of them don't urinate. So everything that they put into their body stays in their blood. If they drink 2 liters of water, they don't pee it out. They gain, the 2 liters stay in them, so their feet can swell, their blood pressure can go up. They will obviously gain 2 kilos in weight. So we know how much fluid to take off because we weigh them. We weigh them after the procedure, and we weigh them before the next procedure, and we take the difference. So let's say after the procedure, they weighed 145. They come back 2 days later and they weigh 151. Well, we know we have to remove 6 pounds of water. That's the kind of thing that the nurses and the nephrologists work out. But that's only the water part. We have to also remove all the potassium, and calcium, and magnesium, and sodium, and chloride, all the things that they've taken in that are now building up in their bloodstream. We do that by altering the chemistry of this solution. The doctor writes the orders for a different type of chemistry of this solution, and that allows us to return the blood chemistry back to normal. Another way of dialyzing a patient is not through the blood, but through the abdomen and through a very small cavity that's in all of us called the peritoneal cavity. Now, normally this cavity shown here as a cartoon is collapsed. You can't see it. There's no fluid in it. It's extremely thin. It's just under the muscle here. So it's like a balloon that's collapsed, but it's been known for many, many years that if you put a fluid into it, it will blow up like a balloon. And so what was worked out over the years, and in particular came into vogue in the 1970s, was a technique to dialyze a patient, but without blood. And what was done was to take a solution similar to the solution we put in the dialyzer, a bit different, into this cavity called the peritoneal cavity, and it blows up with the fluid, And then we just leave the fluid in. And what happens is substances from the blood, poisons, electrolytes, come into this solution. And then after a couple hours, the solution is drained and a new solution is put in. Initially, this was done manually by the patient during the day, but eventually a machine was created called a cycler, and it was thought, let's do it at night when the patient's sleeping. So, and that's how typically most patients do it now, where there's a solution that the machine puts into the abdomen, and it stays there for a couple hours, collecting all the electrolytes and poisons that we don't want to have in the blood. And then the solution is drained and a new solution is put in. And this is done usually 5 times throughout the night. And then the patient in the morning unhooks themselves and goes about their business. And this is actually a better procedure for a number of reasons. One, patients are not hooked up to a dialysis unit, so they're free. Secondly, they're psychologically happier because they can look after themselves and don't have to rely on other people. Thirdly, medically, it's much better than hemodialysis because hemodialysis is a very aggressive procedure done 3 times a week. And a lot of things are done very quickly, especially to elderly patients. We're removing a lot of fluid because we're correcting what accumulated over 2 days. And so they can often have more symptoms after each dialysis procedure. They're more tired. A lot has been taken out of them. They don't feel normal. It might take a day to feel normal. Whereas with this procedure, it's done every day. It's much more gentle. We do a lot less with each procedure. And so because it's more gentle, people tolerate it more. And it's felt to be the ideal way to treat patients now. The US government's been pushing and pushing and pushing peritoneal dialysis at home. Another home treatment is hemodialysis at home, where patients can have a machine brought to their home and they can dialyze themselves through their blood vessels. Some people don't want to stick needles into their arm. And so, not that it hurts, they're just needle phobic. But they can get a technician or a nurse, and if they can afford to, they pay that person, and that person will set up the hemodialysis machine, stick the needles into their arm and treat them. And that can be done five times a week, so that, or even more frequently during the week, in a week, so that you don't have to have as aggressive 3 times a week, 3.5-hour treatments as is typically done in a dialysis unit. The other is a transplant. Some people say, what happens to the other kidneys? Well, they're left in, and the transplanted kidney is hooked up a little bit differently to the blood vessels. But the diseased kidneys are left in because they still may be making vitamin D, 125 vitamin D, or they still may be making some erythropoietin, or they still may be functioning a little bit. And the more function, the better. So we never take out the kidneys. In fact, even on dialysis, there are people who have kidneys that are still functioning, either hemo or peritoneal, and that's great because they tend to do better. The ones that still have some we call it residual kidney function, those patients do better, and we try everything we can to maintain, even if they have 5% of their function left, that's still better than not peeing at all. And we try to do everything we can to maintain that remaining 5% as long as possible, or whatever it happens to be. As far as future work, people are working on what are called xenotransplants, which are organs that come from a non-human, typically a pig. You might have been reading in the news recently, there were 2 xenotransplants that were done on patients that were brain dead, and the families allowed the doctors to do a quick trial. The kidneys were not put inside, were put outside the body and hooked up, and they were studied for about 48 hours or so. These are pigs that are not normal. They've had a gene called alpha-gal removed because the alpha-gal gene has been found to be very important for what's called hyperacute rejection. So when you reject a kidney or any organ, we divide it up by the time it took. Hyperacute rejection is rejection that occurred within, minutes to hours. Acute rejection is rejection that takes days to weeks. to occur. And then there's chronic rejection where you're fine for months, and then all of a sudden, after a year or two, the kidney starts to reject. So this alpha-gal gene has been found to be very important, and we basically solved the hyperacute rejection. And now what will happen with future studies is to see whether these xenotransplants develop acute rejection and chronic rejection. Now there's a separate issue with organs from another species, and that's something called PERVs, P-E-R-V-S. These are viruses that are actually part of the DNA of that animal. And so the pig has like 50 different PERVs. These are viruses that the doctors are afraid might get reactivated when that organ is put into a human, and now that human will have all these pig viruses floating around. That's obviously not a good thing. So people have actually knocked out the PERVs in pigs, and that at least practically can be done. It's difficult, but can be done. It was done several years ago. That has to not be an issue. So we talked about acute and chronic rejection have to be solved. The PERVs have to be solved. And then there's other things that occur where you get inflammatory pathways activated that can lead to clotting, where the blood clots and the organ can stop functioning, not because there was rejection of the organ, but because the blood vessels throughout the organ or going into the organ all clotted off, and now you have no blood flow. So that's going to have to be solved too. So it's probably going to be, 6, 7, 8 to 10 years before all these things are solved. But eventually, at some time in this century, we're going to be solving the organ shortage in part from xenotransplants. The other separate area is the development of an artificial kidney, and that's something that I've been working on here, and there are some other groups working on not exactly an artificial kidney, but components of the kidney that can be man-made that might replace some of the functionality. So I think with that, I'll stop here. Please continue to look after your kidneys, get your creatinine measured throughout your life, know what your kidney function is. There are things you can do to keep your kidneys healthy. Probably the simplest, well, not the simplest, but probably the most straightforward thing you can do is do not develop obesity, do not become overweight where you become diabetic, because that's something that's absolutely 100% preventable. Keep your heart healthy, because the heart obviously is the organ that pumps blood to the kidney. Check your blood pressure. Make sure your blood pressure is always kept within a normal range. And if you do these things, in most people, you can get well into your 80s and 90s and 100s and have kidney function that's not normal because of this normal decline that I showed, but you'll prevent yourself from ever needing renal replacement therapy. So with that, I think I'll stop.